Good evening. This is Lauren Dunlap, Executive Director for Advocacy and Awareness for Immune Disorders Association, or AAAAI, in Charlotte, North Carolina, and I'm excited to host this evening's educational webinar. AAAAI's mission is to provide support and advocate for the greater than 25 million Americans living with immune disorders. AAAAI's works to promote research and create better awareness of immune disorders. This is AAAAI's 9th of 12 educational webinars for 2021, and this evening I will be joined by allergist immunologist Dr. Doug Johnston of Charlotte, North Carolina, who will be discussing hereditary angioedema, triumphs of medical progress. Dr. Douglas T. Johnston is an allergist clinical immunologist at Carolina Asthma Allergy Center in Charlotte, North Carolina, and an assistant professor at Edward Via School of Osteopathic Medicine in Spartanburg, South Carolina. Dr. Johnston received his medical degree from the New York College of Osteopathic Medicine in Old Westbury, New York, and completed his residency in internal medicine at NYU Long Island Hospital, which is formerly Winthrop University Hospital in Mineola, New York. Dr. Johnston then completed a fellowship in allergy immunology at the University of Alabama at Birmingham. Dr. Johnston has served as chair of the Allergic Skin Disease Committee and is the current chair of the Urticaria Angioedema subcommittee of the American Academy of Allergy Asthma Immunology. He has served as a principal investigator for many hereditary angioedema therapeutics used today and author of over 50 publications of angioedema. He has been actively involved with the education of children with hereditary angioedema in collaboration with the Hereditary Angioedema Association and continues to learn from his patients each day. Dr. Johnston, thank you so much for being with us this evening.
Thank you, Lauren. I appreciate the invitation to talk about something near and dear to my heart, which is hereditary angioedema. This is what I plan to do today is kind of walk you through the story of hereditary angioedema over the past 20 years, and I call it triumphs of medical progress because of the strides in therapies and development of medications for this rare disease. And you'll see clearly how it's progressed in recent years. These are a few disclosures. And really what I want to do is one, give you an idea of what the swelling is from in HAE. It's really different than other forms of swelling. I also want to give you a glimpse of how patients with HAE live, both before and today, as well as discuss how treatments have changed over the years, and hopefully serves as a model for other rare diseases and how things can change rapidly when there's collaboration in research and development. So I think a good place to start is simply what angioedema is. It's swelling of the deep layers of the skin or mucous membranes, and what's important is it can be caused by different mediators. And I think back to some of my first experiences seeing patients with angioedema, which was in medical school in the late 90s. And one of the experiences that I vividly remember is an argument between an allergist and an ENT doctor. And they were standing in the hospital next to a patient that was admitted with tongue and throat swelling. She was able to talk, and they were arguing about when she should be intubated. She didn't look like the swelling was very severe, but the allergist wanted to intubate early, and the ENT doctor felt that it wasn't severe enough to intubate the patient. And the allergist actually won. And the reason the allergist won this argument is because this was late 90s, and the patient had hereditary angioedema for which there was no treatment. So one of the treatment options for throat swelling in this disease at the time was to intubate them, let the swelling take its course, and then several days later, extubate them. So thinking through angioedema, this is sort of a list that I often think about in my head when I'm seeing patients with angioedema And it's not necessarily to explain all of them, but really for you to understand that there's different mediators, there's different ways you can swell. And most people think about histamine when they think of swelling or hives. And histamine is often the cause of swelling in an ER, and you can have histaminergic swelling from allergy or even from not allergy, right? You can have autoimmune histamine release and have severe facial swelling. In another condition, the use of aspirin or nonsteroidal anti-inflammatory medicines like ibuprofen or Aleve in susceptible individuals can cause swelling by a different mechanism through a mediator called leukotriene. But the focus of today is this unique type of swelling caused by a chemical called bradykinin, which is very different than these other swelling types. And some of the conditions where we see bradykinin-mediated swelling obviously is hereditary angioedema, and there's also acquired angioedema. And ACE inhibitor, some patients on ACE inhibitors can have bradykinin-mediated swelling. You may have heard or seen patients that have swelling of the head and neck because of ACE inhibitors, and that's actually because ACE helps break down bradykinin. So if you use a medicine that inhibits that function, then bradykinin is around longer and can cause swelling. So the question then is, what's hereditary angioedema? So to summarize, it's really a debilitating and potentially life-threatening genetic disorder. And it's caused by a deficiency in a regulatory protein called C1 inhibitor. When this protein is functioning, it's keeping different hematologic cascades in your blood in check, and it's preventing unchecked production of bradykinin, which can cause swelling. And this condition, since this protein isn't working properly, there's periods where you can have severe swelling. And this occurs without itching and without hives because it's from bradykinin. And if this hits the tongue or the throat and you don't know you have it, and you don't have the right treatments that are specific for bradykinin swelling, it's very dangerous. And it has a 30 to 56% mortality rate, as opposed to, say, something like food allergy, which has a 1% mortality rate. So the story of hereditary angioedema kind of begins a while back. Looking back in the mid-1500s, Donati described a case of angioedema without urticaria, which is hives. This was swelling without hives in a young Italian count. And we think this could be one of the first descriptions in the medical literature and history of HAE, because that is the hallmark of HAE, swelling without hives. In 1888, the great Sir William Osler described a hereditary component of swelling without hives in multiple family members, which we think, looking back, was HAE. But it wasn't until 1963 that Virginia Donaldson and Dr. Evans recognized and discovered that C1 inhibitor deficiency was the cause of HAE. Now, we said it's a genetic condition, and the way this is passed, this is an autosomal dominant pattern. So this means if a patient or a person has hereditary angioedema and has children, each child has a 50% chance of getting hereditary angioedema because it's a dominant gene. So about 75% of people with HAE have a parent with HAE. So there are a group, about a quarter of people with HAE have a spontaneous mutation in their genes, and they're the first person in the family to get hereditary angioedema. But then this autosomal pattern will then continue. So each of their children will have a 50-50 chance of getting it. It doesn't sort of hit any race, gender, or country. It's and reliable data on incidence is really lacking, but we think it occurs in about 1 in 50,000 individuals. Now, looking back in early treatment efforts, in the late 90s, there was research using plasma. Plasma is used for all sorts of therapies, especially in the immune deficiency space, and recognizing that this C1 inhibitor protein is in plasma. So donor plasma could be, we could use donor plasma and obtain the C1 inhibitor and use that as a therapy. And some of this research was done in the 80s. However, the AIDS epidemic kind of put a halt to plasma-derived research around this time, and C1 inhibitor didn't come to market as a therapy in the 80s or 90s. However, research did continue in Europe, and these plasma-derived C1 inhibitor products became available in Europe, but not the United States. Now, thinking about this time in history, we didn't have our first FDA-approved targeted therapy until 2008. So this is a glimpse of how people lived with HAE around this time. And this is a web-based survey of over 450 HAE patients prior to the first targeted approval of therapies. And what we learned was that patients with HAE didn't really live a normal life. They were unable to engage in normal activities for 20 to up to 100 days per year. A third of these patients underwent unnecessary surgery because some of these attacks are associated with abdominal pain. More than half missed their day of work because of their most recent attack, and close to that missed their day of school because of this. But perhaps these next statistics was a surprise to even people that were treating HAE, and that's 100% felt the disease prevented them from advancing in school. And the majority of people felt they were unable to consider certain jobs or even advance in their career because of HAE. And this is mainly because of the severity and the unpredictable nature of swelling. So thinking about what this protein is, so we're in the early 60s now, and C1 inhibitor is discovered in the 60s, and it's discovered as a regulatory protein in the complement cascade, and that's how it gets its name, C1. And you could see the little C1 inhibitor in red, and we're not going to talk too much about these cascades, but when I say it's regulating it, it's inhibiting it. So it's stopping the flow of this cascade. So that's what it does. And then what we later learned is that the same C1 inhibitor was also controlling another cascade in the blood called contact activation pathway. And it's this pathway that's important in HAE. This is sort of some of the key features in HAE of what it's doing in the contact pathway. It's blocking multiple steps so that this pathway does not continue. And what it's doing, it's blocking, one of the key steps is blocking kallikrein, and kallikrein can cleave off that little green triangle, which is bradykinin, right off this other high molecular weight kininogen. So what C1 inhibitor is doing is it's preventing it from breaking off bradykinin. And what happens in HAE is the C1 inhibitor isn't functioning, and now kallikrein is unchecked, and it can chop off that triangle, and now it can release bradykinin. Now, once bradykinin is released, it actually has a place to bind. It has a receptor on blood vessels, and it will bind to its receptor on blood vessels, and what it will do is it will make the blood vessels leaky. And fluid, not blood cells, but fluid will leak out of blood vessels and accumulate slowly in tissues. And that's the cause of swelling. So it is not something that's inflammatory. It is not something that's related to histamine. There's no itching, but there can be pain. Now, the areas that swell there are many places in the body that can swell. The most common places are the extremities, like hands and feet, face. But one of the unique features of HAE is that many patients have abdominal swelling attacks. Now, sometimes they're visibly swollen, and sometimes they're not. The swelling is in the bowel wall, and this is extremely painful. And about over 90% of HAE patients have these attacks. But the most feared attack is laryngeal attacks, because the laryngeal attack, because it's in the throat, it can block the airway and can lead to asphyxiation. Now, the presentation of these attacks is different than attacks in allergy because they're slower. And they vary tremendously among patients, and they tend to have a pattern of gradually getting worse over the first day, and then sort of hanging and then slowly resolving on their own. And an attack can be anywhere from 2 to 5 days. Now, I often think about this as the onset is in childhood. So I always ask patients with swelling if they had episodes as a child, because the mean age of onset of symptoms for HAE patients is often prior to age 12, with about half experiencing their symptoms by, before age 12. Now, this is from data prior to modern medicines, and the time between the first attack the patient had and an accurate diagnosis was 1 to 2 decades. Now, it's better now, but still, there's still a lag, because this is a very rare disease that has symptoms that look like common diseases, so it's often misdiagnosed. This is an example of a face and laryngeal attack in a patient, just to give you an idea of how disfiguring and severe the attack can be. And these attacks can last up to 5 days. The abdominal attack and the laryngeal attack really create a severity level and urgency unlike some of the other attacks, but they're all very debilitating and have tremendous impact. The abdominal attack can gradually become so severe with pain that it mimics a surgical abdomen, right? So a doctor, if they don't see the visible swelling, they may assume that the patient may have appendicitis. And that's why a third of patients back when this data was taken had unnecessary abdominal surgery. Now, the problem with the laryngeal attack, it's very dangerous if untreated. And 50% of HAE patients will have at least one laryngeal attack in their lifetime, but they don't know when it's coming. So we never know if, patients are always on edge that this laryngeal attack may come. And we know this because we have studies of a 30-year-old that had 100 laryngeal attacks, and we have a 9-year-old that has who passed on the first laryngeal attack. So these laryngeal attacks can occur at any age. So just because you don't have them when you're younger doesn't mean you're going to always not have laryngeal attacks. That's very stressful, and living with that thought that it could happen at any time is extremely daunting and stressful for these patients. Now, this is not obviously allergic swelling, but there are triggers that can precipitate the cascade and therefore lead to bradykinin release in these attacks. And a lot of these swells actually don't have a cause, or people can't identify it, but there are some triggers that many patients report, such as emotional stress or infections or repetitive motions, and then surgical and medical procedures. So for instance, if you are going to have a wisdom tooth removed and you have HAE, it's really important that you put together a plan with your doctor for pre-treatment and pre-procedural prophylaxis with medications to avoid a severe swell several hours later. And then some medications can worsen HAE, specifically ACE inhibitors and oral contraceptives. And that's because estrogens has an influence on this disease and actually make the attacks worse and more frequent. Diagnosis looks simple on paper, but it's not always that easy because these tests aren't perfect and sometimes we get indeterminate results. But when it comes to HAE due to C1 inhibitor deficiency, there's two types, type 1 and type 2. In type 1, you don't make enough of the protein and therefore the function is low. In type 2, you make C1 inhibitor protein, but it doesn't work, it's dysfunctional. And you could see that there is also this AAE, that's an acquired form of C1 inhibitor deficiency. It's not hereditary, it usually is a similar presentation, but after age 40, and they look like type 1. Type 1s have low protein and low function. Type 2 have normal protein, but low function. What you could see here is the best screening test is a C4 level. It's measuring a component of complement that happens to be low in all of these. Now, the way type 1 and acquired is distinguished is through another complement protein called C1q, which will be low in the acquired form, but not the hereditary form. Now, I'm going to shift gears and talk a little bit about progress in therapies over the years, and it's been an exciting part of my career to be treating HAE patients back then and see how things have changed in recent years and how it's impacted lives. It's been a very gratifying experience for me as a clinician. So since I don't consider myself old, we're going to take you back to the not so distant past. And this is around late 90s, year 2000. And we didn't have any modern targeted therapies. We were using, to treat attacks, we're using fresh frozen plasma. And we used fresh frozen plasma for attacks because what's in plasma? C1 inhibitors in plasma. And oftentimes this worked, and sometimes it did not. But it was the best we had to try to get people out of attacks. And this was often used for severe attacks. Now, at the time, to prevent attacks, the only medicine we really had was androgens, which were male hormones, testosterone-like derivatives. You could see the problem here is while these medicines sort of helped increase the little bit of C1 inhibitor these patients had and maybe prevented attacks, they had a lot of side effects, such as weight gain and cardiovascular disease, risk of liver cancer, not to mention the masculizing features it would create in women who took these medicines. It was not ideal. Now, in 2008 and 2009, after clinical trials, plasma-derived C1 inhibitor finally gets approved in the United States. And there's two products that come to the market, and one was for acute attacks, and one was given regularly every 3 to 4 days to prevent attacks. So these two products, although they were both plasma-derived C1 inhibitors, they were approved for different reasons. And these were given intravenously. And this was a major breakthrough for our patients because now we had a medicine that would really treat attacks rapidly and a safer medicine for prevention. But the problem here was that if you were doing prevention, it did require IV access. And while we would train patients to self-administer IV, you know, not everyone has good veins, and this became a problem and sometimes would lead to port placement, which has its own set of issues. In 2009, a medication called decalintide comes to the market, is FDA approved for treatment of HAE attacks. And this was a subcutaneous medicine, and it is an inhibitor of serum kallikrein. And this was approved for 12 and up. The problem here, though, however, was that this had to be administered by a healthcare professional because it had a very small risk of anaphylaxis. So this was okay if you're in the hospital or had access, but patients always really want to treat these attacks as early as possible, and this was not one they could self-administer. In 2012, a medication called icatibant comes to market, and this is a subcutaneous medication approved for attacks for 18 and up, and this is actually a bradykinin receptor antagonist. And on these little diagrams, I'm showing you where the medicine works. So this is actually working at the receptor where bradykinin binds. And this was a medication that was in a pre-measured syringe, and it could be stored at room temperature. And this was a breakthrough in self-treatment because patients could carry and treat at any time compared to IV, where some people were able to and some people had more difficulty with IV therapies. Now, these therapies are being used. However, at the time, there were periods where it was difficult to get plasma products, whether it was processing of plasma or shortages in certain medications. And one of the ways that this problem was solved was the use of recombinant technology to make a human C1 inhibitor protein using a transgenic rabbit. So you have a rabbit given the DNA instructions from a human to make C1 inhibitor, and then the C1 inhibitor comes out of the rabbit breast milk, and it's human C1 inhibitor that can be used as a therapy. And this was approved for acute attacks for HAE in 2014. Now, a few years ago in 2017, we have sort of a shift in HAE prophylaxis. And I kind of label this sort of a new age because we're moving into preventative therapies that are easier to administer and perhaps showing in studies to work better. And this medication, Haegarda, is subcutaneous plasma-derived C1 inhibitor given every 3 to 4 days, and it's based on weight. And because this was subcutaneous, this was much easier for patients to administer. And some of the patients that relied on ports were able to get these removed, which is great because these ports can get infected and can clot. So this was a big breakthrough for some of these patients. And this medication, if it's used every 3 to 4 days, had reduced attacks by 95%, median reduction. Now in 2018, a medication, lanadelumab, was FDA approved for prevention of HAE, and this was a monoclonal antibody against kallikrein, right? That's one of the blocking kallikrein was one of the features of C1 inhibitor, right? So this is a monoclonal antibody that would bind to kallikrein and prevent it from breaking off the bradykinin. And this was approved for prophylaxis in ages 12 and up. And what was different here was the dosing regimen. So we have burden of illness and we have burden of treatment. And this was a lower burden of treatment for patients because it was a 2 milliliter subcutaneous injection that's administered at home every 2 weeks. And this the study showed an 87% mean reduction in attacks. And then recently, just in December, the first oral preventative medication, at least targeted oral medication for HAE prophylaxis, was FDA approved, and that's berotralstat. And that's an oral kallikrein inhibitor. And that showed by taking one pill once a day, there was a 44% mean reduction in attacks. So thinking about how we treated patients in the year 2000, a lot of patients would ride out attacks of the hand and face. They would go to the hospital for pain management, for abdominal attacks, and they would perhaps even get intubated and get FFP for laryngeal attacks. And that's very different than what we do today. Those patients had to modify their life tremendously. Many didn't travel because of fear of an unpredictable attack. Treating patients now is different. Now, physicians have several guidelines to guide us on the best evidence-based approach to managing these patients. There's the World Allergy Organization guideline, there's the International HAWK guideline, and then the Medical Advisory Board of the HAEA has a wonderful guideline. And we now have 8 FDA-approved targeted therapies. We no longer think of androgens as a first-line therapy. We now have a goal that every patient with HAE should have a medication to treat attacks and a written treatment plan. And many of those may also have a medicine to prevent attacks. We're much more aggressive about testing family members because there's increased awareness around HAE. And we're more cognizant from what we've learned over the years of the quality of life in HAE, and the total burden of disease includes not only the burden of attacks, but how people live in between attacks because of the unpredictable nature of the disease. Our discussions with patients when we see them are changing. We used to have discussions trying to keep them out of the hospital. Now we're having discussions on what is the best therapy for them. We're now using shared decision-making because there's multiple therapies, and we're having patients be very involved in their care. And this is really the best model. Patients' expectations are changing for the better. And that's because the therapies are more targeted, they're safer, and they're easier to administer. So on that note, I'm just going to sort of close, and I'm happy to answer any questions on HAE. Thank you.
Thank you, Dr. Johnston. Yes, sir.
Yeah.
Go ahead.
I also was going to plug Ada's next webinar, which is August 13th, and that's urgent care versus ER, what to know and when to go with Archie Sims. It sounds like a very good, that's a topic relevant for many patients.
And this crowd included with the HAE patients for sure. Thank you, Dr. Johnston. And just a reminder to our audience, you can type in your questions in the question box there. And when you just touched on shared decision making, Dr. Johnston, I got to ask, what does shared decision making look like to you as a provider when you are treating an HAE patient? And can you just touch on that?
Yeah, I'm happy to. So the idea of shared decision making is that both the doctor and the patient are involved in the decision. So there's different models. The way I view it in HAE is the first thing I do with patients is I gauge how much they understand HAE and how well they know the current landscape of therapies. And if they don't have a good understanding, then step one is for me to provide that understanding. So I would make sure that they are well versed in a lot of the things we talked about today, as well as what medicines are available and how they're administered and the pros and cons of these medicines. The next step is to really get an understanding of that patient's preferences and what's important to them. It's going to be different from person to person, and this plays into decision. Some people, like for instance, for some people, the idea of a pill is much more inviting than an injection. But I've also had patients say, you know what, I'm terrible with pills. I would forget it. And I like the idea of using this other therapy. So getting an idea of what's important to the patient is a feature of that. And then usually the doctor and the patient would then have a discussion based on all these elements and what's important to the patient on what therapies are the best for that situation. So oftentimes there's an agreement because there's a good understanding on both ends. Sometimes there's disagreement, and that has to be hashed out. So the doctor then will have to maybe discuss why they feel it's good or bad, and then they kind of go back to make a shared decision.
Sounds like, Dr. Johnston, your model, you could take that same model that you use with your patients and kind of spread that across the other specialty and primary care areas as well. I'm a big advocate for shared decision making, as you know, and I always like to get different providers' perspectives on what that looks like. So thank you for sharing that. Question for you is, have you noticed, has there been a shortage of any HAE treatments due to the current plasma shortage because of the pandemic? Have you seen any shortages over the last year and a half or so?
I personally have not, and that's because, and there may be, but my patients have not experienced that. And I think because of previous shortages in the past, I do feel that a lot of the companies have prepared for such things such as this, and have plenty of supply for these therapies. But a shortage is always possible. So I always tell my patients to reach out to me if they change insurance, or if they're not able to get the medications. We really need to know right away.
Thank you. So, Dr. Johnston, you're an allergist immunologist who treats HAE. Who else treats HAE? What other specialists are out there that may treat this condition?
So I think allergists are the specialty that treat HAE the most. I know many patients who live in rural areas, I've seen primary care doctors treat it. I've seen hematologists treat it. So it really depends on the doctor's comfort on treating HAE, and it depends on access to HAE expertise. Hopefully telemedicine may help that. I know there are patients I've seen who live in rural environments, and they have a doctor in town treating it, and then they might touch base with me once a year, just some overseeing what's happening. So that's a good model for patients that live in rural environments. And I know in Europe, dermatologists also treat HAE.
Wow, that's interesting. I would have never thought that. Question from Derry. Is it normal for people to be diagnosed in adulthood? Is it because it is not easy to diagnose? I was recently diagnosed with type 2.
Yeah, so it can be diagnosed at any age. It just so happens that most attacks start in childhood. They don't have to. I have several patients, their first attack was in adulthood. Now, there's the reason for the lag sometimes is because, one, people don't think of HAE, and if you don't think of it, you're not going to really look for it or diagnose it. But one of the other reasons is type 2 HAE. So there's thinking to get a diagnosis of type 2 HAE, you need an abnormal C1 inhibitor function, because the C1 inhibitor protein, which is the C1 inhibitor protein will be normal, and that's kind of an easier test to obtain. The functional test is trickier. There's a lot of elements that can throw off the test, and it could be falsely abnormal, and it's a hard assay to run. In addition, the commercial assay for C1 inhibitor function, is an ELISA, and this test isn't a direct test that measures C1 inhibitor function. There are better tests like the chromogenic test, but very few labs do them. So it has to, in people that have had really long lags that I've seen, it's usually patients who have type 2, who have borderline C4s, and that can happen. And it's oftentimes patients that don't have a family history, where they're in that 25% of people that have the spontaneous mutation. Good question.
Thank you, Dr. Johnston. Kind of piggybacking off of Derry's question, well, we know you can develop it later in life. So you have the type 1 and you have type 2, and you briefly mentioned the acquired or AAE type. what causes are there? Is it an environmental cause or just predisposition
So,
to getting that?
so there's type 1 and type 2, which is C1 inhibitor deficiency. There's also an HAE with normal C1 inhibitor, which is these are multitude of genetic disorders that affect the cascade. And then there's acquired C1 inhibitor deficiency. Acquired C1 inhibitor deficiency is typically presents in adulthood, and the cause of the deficiency is typically hematologic process or malignancy or autoimmunity.
Great, thank you. Are those, and as we're talking about this, all HAEs and the acquired as well, they're all pretty rare across the board. Is that correct? If you had to guess, what's the percentage of the population that it would affect?
It's very low. HAE 1 and 2, we think, is about 1 in 50,000. We think HAE with normal, which are these, many are unknown. There's some mutations, is about 1 in 100,000, we think. So these are
Wow.
very rare. Yeah.
So you mentioned this earlier, Dr. Johnston, about the fluid that leaves the blood vessels. So what happens to that fluid? We know it causes swelling, but does it actually cause any damage to the blood vessels themselves as well? Since it's the blood vessels are losing fluid, what happens there?
So to my knowledge, I'm not aware that it causes damage to the blood vessels. So it leaves through gaps in blood vessels, but it doesn't go back in that way. What happens is the fluid that's accumulating in the tissues, you see how the tissues can stretch around it. The fluid has to get reabsorbed through lymph, and then eventually put back into it gets through the lymphatics, goes back into the heart.
Okay, thank you. Here's another question from Derry. Could HAE be complicated by other autoimmune diseases?
Well, HAE is always complicated when there's other disease processes, right? So I wouldn't say that we have a lot of data saying that HAE patients get autoimmune diseases, but if you had other diseases, let's say you had a disease of the abdomen, that would be really confusing. So if you have a condition with chronic abdominal pain, this would be really very troublesome in an HAE patients, because you want to treat these attacks early, and if you don't know if it's an HAE attack versus something else, it may delay treatment. So these other processes or comorbidities can make it harder on HAE patients.
I mean, I think that's any comorbid or other underlying condition in general. So how fast will treatments of an acute attack work?
So this really depends on the person. So all of these treatments we talked about, they work. They've been proven in clinical trials. They're FDA approved. They work at different speeds for different attacks in different people. But one of the overlying themes we always talk to patients about is that to treat as early as possible, because the earlier you treat, probably the faster the medicine will work. And this makes a lot of sense, right, Lauren? Because what's happening is fluid is slowly moving out. So if you're halting the process of the fluid moving out, then there's less fluid in the tissues that have to get reabsorbed. So you can get over the attack hopefully quicker.
Thank you for explaining that. I don't want to go down this rabbit hole, but I will ask this question, and this question is my question. So we're talking about C1 inhibitors, and we're talking about the complement system. Can you explain to our listeners what that means and what part of the immune system that actually entails, without getting, again, going down the rabbit hole too deep? Can you just touch on that?
C1 inhibitor C1 inhibitor is a regulatory protein, so it's not one of the complement proteins, right? It's one of it's a serine protease inhibitor. It's actually working to prevent the cascade. So the reason it's important in HAE is because this protein that's an inhibitor in the complement system is also an inhibitor in the contact system. So it's the contact system abnormality that leads to the dysfunction and recurrent swelling in HAE. But technically, it is a deficiency in a complement, regulatory protein. It does not lead to immune deficiency, whereas a deficiency in complement proteins, such as if you had C3 deficiency or C4 deficiency, could lead to other problems that are more in the immune deficiency spectrum. But because this involves a component of the complement system, I like to kind of put it in the immune disorder category.
Thank you. One other question is, can swelling move to different locations in your body from one area to another?
Yeah, these attacks can move, and what we often worry about is a lip attack or a facial attack moving to the tongue and throat, and suddenly it's a different attack. It's a more severe attack. So we always try to treat these early. We try to tell people now in 2021, you don't have to ride these attacks out. There are therapies that can help rapidly. Some of the ways people dealt with these attacks in the past is they would ride them out. And even in 10 years ago, patients would have on-demand treatment to treat attacks, but they would save them for more severe attacks, and they might ride out a mild facial or a hand. And one of the reasons we don't want them to do that is because these attacks can move.
Great, thank you so much. One other question that just came through. Have you, Dr. Johnston, personally treated any active duty soldiers who have had HAE? This listener is in the military, and he hasn't ever met anyone in the service with it, and nobody in the military seems to be familiar with it.
I guess you'd probably want to see an allergist. There are military allergy clinics that have familiarity with HAE, and what I would say is they may not have seen it because it's rare. So it's just a matter of getting into sort of an allergy military clinic, but they should be pretty well versed. Most board certified allergists will know about HAE.
And have you ever treated any active duty soldiers that have it?
I have not.
Okay. And I just wanted to mention to this listener, this is a rare disease, and any rare disease, it may take you longer to meet somebody that has the same diagnosis as you or even similar. You might wait, 5 years, 10 years, but eventually you will run into someone that has the same diagnosis as you, and then you don't feel as isolated. It makes a world of difference for sure. And there are support groups out there and other ways you can connect to patients. So don't feel like you're, alone on this planet with your diagnosis, for sure. And I will say that as a rare disease patient myself, and it took me, I think it was 3 or 4 years before I met another patient that had the same diagnosis as me. So it is a life-changing experience when you meet that patient. All right, well, Dr. Johnston, Thank you for being with us this evening and volunteering your time to educate our community. And thank you to our audience and tuning into this evening's presentation. Don't forget to register for our next webinar on August 13th with urgent care versus ER, and what to know and when to go with the nurse practitioner Archie Sims. And please take a few moments, if you don't mind, to fill out a quick survey, 3 or 4 question survey, the conclusion of today's webinar, to help us better serve our patient community. Also, if you enjoyed tonight's presentation, please consider making a tax donation to AAAAI on our website at www.godoada.org. Your contribution helps us greatly to be able to conduct educational initiatives such as this evening's webinar, and to be a resource for our patients and medical community that we serve. This is Lauren Dunlap for Advocacy and Awareness for Immune Disorders Association, and we hope you have a fantastic evening. Thank you so much, Dr. Johnson, and thank you to our audience.
Thank you. My pleasure.
Take care. Bye.
Good night.